Hello and welcome back to the Advancing Health Innovation Show. I'm your host, Michael Stamatinos. And if you're new to us, man, really excited to have you here. It's great to be here because you know what? We're having some really fantastic conversations with some exceptional leaders that are painstakingly shaping the future of healthcare. Now, we're really passionate about things like access, healthcare innovation, adoption, and leadership. And if it's your first time tuning in, let me just sort of take a quick step back to share with you what we're trying to accomplish here with the Advancing Healthcare Innovation Show. So we're focused on bringing real stories of innovation to life. And that means highlighting real people that are in the trenches doing stuff within our space and giving them the platform to be able to share some of the wins, some of the learnings, and what they're doing in the future. So we've got an amazing action-packed year. If you haven't checked out any of the historical interviews, make sure you hit the subscribe button now, wherever that is, ring the bell, so that any of the new content goes right directly to your inbox. And as you know, our field is evolving quickly, and it's crucial to have leaders that are envisioning the future and also eagerly embracing innovation to address some of these pressing challenges. And our next guest on the show is actually one of these leaders. I'm excited to introduce Mark Fulton. He's the Director of Population Health and Innovation at Sentara Healthcare. So he sits in a really interesting seat with respect to healthcare innovation because he's leading teams that are not only responsible for creating and implementing and maintaining things across their health plan, but also within the health system. And his role is pivotal in measuring and continuously improving many of these interventions, ensuring impactful outcomes on their members in this population. So Mark has a really interesting background, which we'll go into more in a little bit, around health plan management, and he's become a really key player in Sentara's health plan. And he's at the forefront of introducing innovative solutions that cater to specific needs of their members, leveraging both ready-made off-the-shelf solutions, but also custom-tailored interventions to achieve meaningful outcomes. So his passion for driving healthcare innovation isn't just around improving systems and processes. It's really deeply rooted in making things better. So we're going to dive into today's conversation and explore his experiences as a leader and pull out hopefully some of these golden nuggets and insights for our community to take back with them and deploy and take action on. So Mark, it's great to see you. Thanks for coming on the show. Welcome. How are you?
Thanks for having me. I appreciate it.
Yeah, so give us a little, you've done some really interesting tours of duty, I like to call them. So give us a little bit of a background on some of the things that you've done and kind of transitioning into what you're focused on today.
For sure. Today, current present day, I'm the Director of Population Health Innovations and Performance Improvement. And essentially what that means is that we, on my team, are broken up into two separate areas, one being performance improvement and the other being innovations. And so what we do on the innovation side is we sort of source problems internally. Sometimes those are based around certain conditions like diabetes, and high blood pressure and other pieces like that. And then what we'll do is we will either source internal solutions to those pieces, or we can also reach out to vendors and procure vendor support there as well. And so then what we'll do is we will implement set interventions, and then on the back end we have our performance improvement team who essentially measures everything we do, and they help us to build business cases essentially to say, okay, this is a problem and this is how we solve it, or this was the problem, here's how we solved it via our innovations, and here's what we can continue to do to continue to improve those numbers as we go along. And so I've been doing this for around 3 or 4 years. Prior to that, I was a project manager here at Sentara, and then prior to that, for about 5 years, I worked at Anthem, now Elevance, doing project management as well. And those project management skills have essentially helped us to stand up all these programs, make sure that we are, continuously using the same processes over and over again or improving them as needed. But it's really helped us to create a playbook to be able to continuously improve all of our numbers.
So it sounds like you have a lot of GSD, getting stuff done.
Mm-hmm.
And that is inherently within your DNA. Can you share the moment or experience that really ignited this passion for healthcare innovation?
Yeah, so for me, I would say that the way that really the moment at which we knew that we needed to make changes and really, as you said, get stuff done, as we took a look at our PWP numbers here in Virginia, that's sort of similar to STARS, but it
Mhm.
is specifically for Medicaid. So we took a look and we noticed that there were multiple instances in which we were receiving 0% or generally pretty low numbers when it came to solving our care gaps. And so what we decided to do is we said, look, let's start at the root of the problem. The problem is that, for instance, with diabetic retinopathy exams, that we weren't getting enough done to be able to, sustain our business. And so then what we did from there is we said, okay, what is the best way to do that? And for us, what we first started with is there was a solution that was already in place when I came on, where we were essentially trying to force our members to an ophthalmologist's office. And there was, some hit or miss there in terms of when they would actually go or if they had issues getting there. And so there was a lot of different things that, the members have had to manage in order to be able to go and close that care gap. And generally speaking, the more steps somebody has to take, the less likely it is that they're actually going to do it. And so for us, we try to figure out, is there a better way for us to ultimately close this care gap in a way that is more efficient and more cost effective for the member? And so in order to do that, we started to look around and see, okay, what are some of the solutions out there that are available to us? And one that particularly came to mind is our partnership with Retina Labs. And Retina Labs basically has a business model where they will go into the home and they will do the diabetic retinopathy exam, and then they essentially have it sent off to an ophthalmologist to to verify. And so we went from
Is that a clinician that's being deployed to do that test, or is that test self-administered, meaning someone has the ability to
yeah,
do that on
so
their own?
it's a tech. Essentially, a tech goes out to the home and
Okay.
does it, and it's it's really it's great because for us, for our members, it took out two barriers for us. First off, there's no cost to them. If they went into the ophthalmologist's office, they would have had to have paid a copay. And then the
Right.
second piece is the transportation, whether they have a car or not, or they have to take an Uber, or these other pieces. It's just generally more steps that we're asking a member to manage. And so being able to sort of call them and say, hey, we have a tech that can come out to you and can take care of this. And then refer you to another provider if needed. If there is diabetic retinopathy present, then we're able to help them to get an appointment as well from there. But yeah, for us, I think that the real point for us was, as we said, we're not, from a business, we're not solving this problem, and we need to solve this problem. And so we just went through each step to see, does this fix it? Does this fix it? Does this fix it? Until we come to a solution that ultimately does fix it, and then we'll move on to the next problem and sort of repeat that process over and over again until all of our numbers are
How fast is that iteration? How fast are you going through that cycle? Talk us through that, because it sounds like you're moving quickly, but I don't want to assume that. Talk me through that.
Yeah, so it depends. So at Sentara, the contracting process does take some time. And so if we ultimately get into a contracting process, that's generally about 6 months. But prior to that, sourcing solutions, generally that happens on, really a day-to-day, week-to-week basis until we've sort of looked at all of the possible solutions we had and then break it down, via RFP or whether, not as traditional as an RFP, just looking at each one of the possible solutions and then choosing from said solutions from there. And so that happens pretty quickly. That I would say happens anywhere between weeks and a month.
Mm, Because to me, it just seems, how do you balance that in terms of the need for rapid innovation with respect to your, I'll just call it, the internal barriers or the gauntlet that you have to go through that are inherent, that are in place,
Mhm.
but still wanting to deliver value for the members? Because you mentioned about your scores. Well, clearly, if you want to go about it in a fast, efficient manner, there's
Yeah,
still a lag. There's still quite a bit of a lag.
yeah.
So, what's the expectation from leadership as they see knowing the barriers that are in place or the milestones that need to take place that take 6 months, a year, what is
Yeah.
their expectation with respect to performance improvement, knowing
Yeah.
that these barriers exist and this lag
Yeah.
exists?
Yeah, so I think that's kind of there's a few answers to that question. So I think for, in terms of being able to how quickly can we solve this problem, generally speaking, the task that we're given is solve the problem and solve it as quickly as possible. And so in a lot of ways that sometimes ends up being a vendor because, if you have to internally make a decision to build versus buy, when you're building something, if you don't already have the infrastructure set up to, if you think about if you're building a house, for instance, right? If you don't already have, the project manager or if you don't have the supplies and all these things, you have to source all of these different pieces. You have to be able to, make sure that there's a foundation that's built. There has to be, all these different pieces. There's hundreds and hundreds and hundreds of pieces that go into building said house. And so that just naturally takes more time. Now, if you have a vendor and they already have all of those pieces, it generally cuts down on the lag time that's needed to be able to do those things. And so for us, it oftentimes ends up being a vendor because we need to solve a problem immediately. And so we go and we solve those things. Now, that being said, sometimes the best way to do it is to start with a vendor, sort of learn how they're doing it, and then in the background, maybe set up, take those lessons you learned from them and set up a possible transition at some point to be able to do it yourself. But generally speaking, the appetite is let's get this done as quickly as possible. And if we can get it done as quickly as possible, study it and potentially implement yourself later on. We haven't gotten to the point where we've implemented ourselves. Generally speaking, with vendors, if they've been doing it long enough, they're lean enough to where they can do it at a lower price point that you could build it yourself. And so if they can do that, there's no real incentive to switch over from a business perspective to switch over from the vendor to doing it yourself.
Right.
And so that's generally how we handle that on a case by case basis.
Interesting. I want to go back to something you said earlier around prioritization around problems, because you sort of sit in that interesting seat where you're dealing with the health system and the health plan. Do you find that many of these problems sort of cross pollinate, are impacting both of the entities? And then what's your, how do you guys prioritize? You mentioned around care gaps around diabetic retinopathy. How did you land on that? To notate that that's something that you can solve that would have material impact. Like, talk me through that process.
Yeah, so I think there's a few different things. So when Sentara is a really unique organization because we do have a hospital and we have the health insurance health plan arm, right? And so I would say that overall, that's a really good outcome for the member. And the reason being is because, if you can get your hospital and your health plan to both be able to be sort of lockstep, then generally the cost is lower for the member than it would be if you have a health insurance that is different from the hospital that you're going to. And so to answer your question, is there cross pollination there? Absolutely, right? There's about 10% of our members that are both hospital patients and health plan members. And so we're working through on our side, making it as seamless as possible. And maybe seamless isn't the right word, right? Because there's seams to everything, but can we hide the seams so that it looks to the member like they're just kind of sort of effortlessly being passed back and forth, and it's the best possible member experience. And so, one thing I will say is that what we're working on right now is we have right now an app that we've worked with a vendor on called Ovia. And so with Ovia, what they do essentially is they do prenatal postpartum. And essentially they're encouraging their members to go to those prenatal and postpartum appointments, which is also a measure that we're measured by ourselves for Medicaid as well. In addition to that, they have some other parenting resources as well, which are important. But the really big thing for us is closing those care gaps. And so we have a similar problem on the hospital side with ensuring that the members go to their prenatal and postpartum appointments. And so we haven't implemented it on the hospital side, but it looks like there's a good chance that we will do that. There's definitely cross-pollination between these issues. And so we haven't gotten to the point where we have been able to sort of connect those two pieces, but it's 100% the goal of the organization to take care of that as soon as possible. With diabetic retinopathy, the way that we landed on diabetic retinopathy is there was 2 years ago, there was zero payout for the health plan, and the PWP payout for diabetic retinopathy exams. And so naturally, leadership said, why are we getting 0% payout? So then the first question we have to ask ourselves is, okay, why is this happening? And then we did research. We saw this was really at the start of the pandemic. People weren't going into the offices. And on top of that, the people that were supporting us, they were no longer able to support us, the company that was helping us there. And so that led us to say, okay, we're going to solve this problem. How are we going to solve it? Do we want to do the same solution, which we've been doing, which hasn't been getting great success, which is let's get them into the ophthalmologist's office. One of the other options we looked at too was it wasn't necessarily to send them to the ophthalmologist's office, but what they do is they work with a number of health plans and they'll set up like one central location for all of these
like
different health plans. And they'll say, okay, everybody come here. It's still the same problem because you have to get there. Right. And so it didn't really solve our problem. And it wasn't exactly cost effective for us either. And so then we said, okay, what is a third possible solution? Can we get somebody to go to them? And is that a viable business model for the vendor and also for us? And so,
but who's involved in all of this? Hold on a second. So who's involved?
yeah.
It sounds like this is a multifunctional, multidisciplinary team. So this isn't just, this is clinicians. This is sort of, yeah. Tell me more about that. I'm just sort of curious.
For us, the primary driver is our government programs team, which is Medicaid and Medicare. And so they're the driver, essentially saying like, we need to be able to, to do this. And then we're the team that needs to solve said problem. So from our perspective, it's not so much the cross-pollination on the hospital side, because from the hospital's perspective, there is a little bit of crossover.
Right.
But when we're talking about an ophthalmologist network, for instance, they may or may not be Sentara, right? And so for us, it's more so, let's just get this knocked out. And so the cross-functional team really is across government programs, but essentially it's, letting them know whether it's our case management team, whether it is, privacy, legal, this is what our intent is, and then get a sign off from everybody that okay, that intent makes sense, your business plan is logical, and we'll pay for it. And so then basically what we'll do from there is we'll build out a business case and we'll say, okay, here's what the overall cost is to the health plan, and then here is what the potential benefit is to the health plan based off of the cost that we're going to pay the vendor. And so once we've done that, and built out an ROI from there, then we are able to push forward. And we've been able to push forward for about 2 years now, a little under 2 years. And we've done roughly a little over about 3.5 thousand in-home diabetic retinopathy exams. And in addition to that, we've also sort of found additional ways for
did you know what the initial baseline was that you were going up against? Because you said there's a dramatic improvement, but what was it initially in terms of diabetic retinopathy tests? What was existing state prior to your intervention?
Yeah, so basically the way that PWP works is that all except for, I believe it's the pregnancy pieces, because you're dealing with two lives essentially. You have to reach 52% of your members to be able to actually get said payout. And so that 52% is 100%. And that's why it's a little complicated based off the way it works, but essentially that is the way that it works. Now, when it comes to pregnancy, I believe it's a little over 70%. And so we were getting zero before when we started, and now we're at 125%. So basically the way that PWP works is you can, after you get past that 50% threshold, you can continue to earn, because you're going up to 100%.
There's basically different tiers. There's different tiers of payouts.
And so we've gone over 125% in the past calendar year, essentially for diabetic retinopathy, whereas we were at 0 2 years ago. And so it's dramatic, right? And so
the incentives align for everyone, not just the plan, but also for the patient to be able to actually get that intervention that's timely, that hopefully, heaven forbid, if they get something and they see something that's on the task you can intervene
Yeah.
earlier rather than later.
Yeah, I would say the PWP program and STARS too, is really what's best for the member. And I actually think that CMS and and also the PWP program really are designed with the member in mind, right? And so basically,
Yeah.
what they're telling the health plans is they're saying, look, we're not just going to pay you for having a member, a Medicaid or a Medicare member. You have to keep them healthy in order to be able to get, to make money essentially. And so what that does is it incentivizes health insurance basically to say, okay, let's keep our members healthy. How do we keep our members healthy in order to get that payout? And so,
Mhm.
like you said, it sort of aligns first what the government is hoping for, which is that that our Medicaid and Medicare patients stay healthy, which then costs them less money, right? And for us, it incentivizes us to keep them healthy in order to get a payout, and then for the member, we have to innovate to solve these problems. They're not just going to solve themselves on their own, right? So they've identified essentially, these are diabetic retinopathy exams. We're having trouble getting those done. We're having trouble with people having high blood pressure, so on and so forth. And so those aren't just going to solve themselves. And so what it forces the health plan to do is say, how can we be innovative? How can we fix this problem so that we can get a payout, right? And so that causes us to then
Yeah.
sort of get the wheels turning, say, okay, let's go into the home.
Mhm.
Let's solve this problem. The two of the biggest problems that we've seen, transportation costs, we've removed both of them, right? And so if we can do that with as many of these measures as possible, it's a benefit to the member because they're not having to pay, they're not having to drive. And for us, the benefit is, well, we went from nothing, earning no payout, to
Yeah.
earning 125%. So like you said, it
Yeah.
aligns from really top to bottom. But the best overall outcome here is for our patients, for our members. And so the goal is to not necessarily have everything be in home, but to solve every problem in the same way, right? So like start from what the problem is, think about what the member's problem is, right? Is it transportation? Is it cost? Is it something else? And then either build or find a solution that solves that problem.
Hmm. That's an amazing example of what it means to align resources, incentives. Can you discuss a time where maybe you sourced an issue, you sourced a problem, and it didn't go as planned?
Yeah, that is a fantastic question. So I would say for us, we we historically, and I'm going to kind of flip this question because it has actually turned out better in the long run, right?
Okay.
But essentially, we sourced with a vendor essentially that was going to do send out tests, send out fecal immunotherapy tests, essentially, which is fit tests, where they are checking for colorectal cancer, right?
Hmm.
And so we initially were working with a vendor on that, and that vendor got bought out, which happens. It happens in business, right? And they went to another vendor who basically said, "Okay, hey guys, you've had this sweetheart deal with previous vendor for 10 years, and it's not working out. We can't do the same numbers that they were doing, right?" Which is
Right.
interesting because you would think that if you got bought, you're at a larger scale and you would actually be able to lower prices, right? But they came to us with that, right? And so we said, okay, now we have a real problem because we were already sort of operating at a baseline where it was getting close to being unaffordable for us. And so we decided then to say, okay, like, is there an efficiency that can be found where we're already going into the home to do diabetic retinopathy exams? Can we also drop off these tests, whether it's HbA1c tests, colorectal cancer tests, all these other pieces too, fits, right? And so we're going to go in. Is there a way for us to, to essentially lower the cost by being more efficient? If we already have somebody going, they can just drop that off. We don't have to pay for the mailing for those pieces. And so we were able to find that. And we actually got an even better price than we had originally, which is great. And we still do mail them out, but we do it at a far less scale because we're able to deliver to the members that were already in the home doing diabetic retinopathy exams for. And the great point is that, those texts can say, here's, I've done your diabetic retinopathy exam, but actually here's what you need to do to send this back. If it's your HbA1c or it's a fit kit or colorectal or something to that effect, right? Here's what you need to do. And then when you're done, just pop it back into the envelope that we gave you and send it off. And so it started off as a loss, essentially, because we're like, wow, we've been transferred over to this new vendor and it's not going to work. How can we increase efficiency so that we can make this work?
Interesting to note. So when the technician is going to the home, is it a one-time visit per year? Like, what's the frequency where they're doing this exam? Is it once a year? Or is it a few times a year? Or
Yeah,
what's the frequency?
it's once a calendar year for
Okay.
the diabetic retinopathy exams if they have the open gap. And so,
So my question then is what other gaps can the technician identify that they can then bring back to create awareness, or is there
yeah, no,
something else?
it's a great question, and I would say that right now I'm not sure that we're necessarily ready to answer that, but I can sort of give you an
Mm,
idea. There are, especially when we're in Medicare, in our Medicare members' homes. I think there are fall risk assessments that are done as well, and so maybe there's a way to be able to say, hey, this is a problem that we noticed we were there. Can you send, a different person out? Or, maybe there's a way that we could also combine the services there, but I know we do have a different vendor that does that. So, the possibility is to say, okay, hey, I was in the home, there's a lot of fall risk here. Can we, can we send somebody out to actually do the assessment, help the member to, to essentially make their home more safe for them, and do that. But that's, it's a great thought.
mm. And I'm just sort of thinking with you and your team, when you y'all are getting together each year and you're mapping out the problems, the issues, which are inherently opportunities to make things
Mhm.
better. What does a good year look like in terms of, because you're all about
Mhm.
GSD, checking things off. What's a good year look like when it comes to attacking some of these problems and solving some of these issues? Like, what's actually realistic and doable where the team feels like there's significant impact?
Yeah, for us, it's really a lot of it comes back to PWP and stars, right? And so it's, have we, based on what we've selected, have we solved the problems that we set out to solve, right? And
Yeah.
so we don't have the capacity at this point to solve every single problem and to have every single payout be 125%. But what we can do is we can choose problems, solve those problems, and then as capacity becomes available, go into the next problem and solve those. So for us, success looks like, did we set out to solve the problems that we aim to solve? Because we're not going to be able to solve all of them based off of our capacity in one year. But did we solve those problems? And I think the second piece is there a positive ROI for the company, right? Because if we're solving a problem, but the cost is far exceeds what the benefit is for the company, it's unsustainable. And so we want sustainable success over a long period of time, and we generally like to build relationships if it's going to be with a vendor in which, there's not going to be, some sweetheart deal where they say, well, yeah, the first year there's a great ROI, but then there's no ROI for years 2, 3, 4, and 5. And so we have to continuously monitor and make sure, is this still affordable for us? Is it still affordable for the vendor? Is it
Yeah.
something that we need to adjust or look elsewhere or build internal? And so for us, it's let's solve the problems we can solve. To solve the problems that we set out to solve, and let's make it as beneficial as possible for both our members and the company to be able to continue to do those things.
I love it how you mentioned, or just around initially, attacking the problem and not necessarily always having to throw. You didn't necessarily say this outright, but you were kind of
Yeah.
alluding to it, not necessarily having to always throw tech at it. Maybe it's a process improvement and
Yeah.
incrementally getting better over long stretches of time. There's been so much hype and talk around AI.
Mhm.
Where, what role do you realistically see that playing within your health plan and the
Yeah.
future of it? Where do you actually seeing it being deployed? Because there's a lot of people talking about it,
Yeah.
but like, where do you practically see it being deployed?
Yeah, so I think for us, AI, like you mentioned, is kind of a buzzword, right? And so in a lot of ways, it means one thing, but what is being sold is another thing. I think for us, AI means machine learning, right? So I think what it is when we talk about population health specifically, I think what we're looking to do is via machine learning, build a profile on our members to say, okay, Michael has this care gap, right? And we know that he is most likely based off of, A, B, C, and D to close this care gap at this time. If he's texted or emailed, or there's a certain time of year, and so we want to be able to build the profile and then essentially contact that member at the most advantageous time to be able to close that care gap. And so for us, it's the answer to your question is we need to be able to build a profile on our members and then use that profile to keep the member as healthy as possible. And so, that to me means that we're constantly learning. And that's why I say machine learning. We're constantly, learning to build out what our customers need based off of what we know about them and their population, where they live, and what their conditions are. And so that's essentially, I think, how we will utilize AI. And at least from a population health perspective, there might be other use cases, in other different ways, but I think for us, it's primarily as a learning about our members and contacting them at the most optimal time.
Yeah, in essence, keep your friends close, keep your members closer, keep your
Yeah,
customers closer.
for sure, for
That's really
sure.
what it boils down to, is know your customer. How do we're kind of tailing towards the end here, but how do people continue to follow your work and some of the things that you guys are working on?
Yeah, so for us, we are always, active on social media, on LinkedIn as well. And we're always going to update, what we're doing and make sure that the things that we're doing are, as visible as possible, not only to obviously the business community, but also to our members as well. And so, we try to make things, when I'm on a show like this, or whether or not
Yeah.
we're doing a press release or something like that, that it's as clear as possible that the goal here is to help the member, right? And so, if we can push out the benefits that we know that members have, but that members don't necessarily know that they have,
Yeah.
that anything like this is generally a positive to be able to get the word out. Because even if it only reaches one person, it's like, wait a second, I'm a Medicare member and I have diabetes, and there is a chance that I could lose my vision, but I saw, whether it was on LinkedIn or somewhere else, that I
Yeah.
can get that treatment in my own home because I don't have time or I don't have transportation, these other pieces, then that's a win, right? Because it cost me nothing to be on here, right? And but the potential benefit to our members is so large that even if it only reaches one person, it's worth it, I think.
Totally. And I'll kind of leave with this last question is, we always ask our guests, what's one thing that our community, our audience can take action on. So if there's one golden nugget that you want to leave the
Yeah.
community with, what can we take action on to make things better?
Yeah, so for me, I think the advice that I always give is, if you're building a solution, start from the problem. I see, and I'm sitting on a lot of pitches, and I sit on all different kinds of things, and oftentimes what I'm hearing is that we have this solution. How can we fit it to your problem, right? And so
Yeah.
that solves sometimes half the problem, or maybe a little bit more than half the problem, but it doesn't actually solve the full problem. So when we started with doing the diabetic retinopathy exams at home, we started from the problem, and we identified that there was issues with transportation and there's issues with cost. And then we built out a solution from there that essentially solved the entirety of the problem, instead of saying, well, we can have all of your members in one place, and have Anthem's members and Cigna's members all be in one place at one time. That solves the problem for you, the vendor, but not for me, who is the customer here. And so I would say always start from the problem, build the solution from the problem. Don't try and fit your solution to the problem. There's a huge delineation on how often you'll reach success if you do that.
Subtle, yet that 2 millimeter shift can be the difference
Absolutely.
between someone at a company making it or not making it.
Yeah, I think I've heard, that if you just moved a plane that was flying from LA to DC, just 2 centimeters, you've moved the nose 2 centimeters, you would end up in New York City and not in DC. Over the course of time, that large, that tiny difference over the course of flying across the country
Compounds.
is the difference between
Compounds.
DC and New York. So it's huge. It's a huge difference.
Mark, this has been awesome. I appreciate you being able to kind of carve out time
Yeah,
to
thanks for
share.
having me. I appreciate it.
Yeah, of course. And for those that have been tuning in, if you found this conversation particularly enlightening, helpful, let us know. Let us know what stood out for you. Would you mind sharing it, liking it, and engaging with it? That's always helpful as well. And for future things that we want to kind of discuss on the show, make sure that you drop us a comment and let us know what you want us to talk about. So look forward to our future conversations, Mark. Thanks for coming on again.
Thank you. Appreciate you, Michael.